Thanks, Steve, for that lovely introduction and fabulous talk this morning with Kathy and Elliot. Thank you. And this really ties in quite well with what's been spoken previously. So, triple elimination, the initiative aims to simultaneously eliminate mother-to-child transmission of HIV, hepatitis B, and syphilis. Now, the basic tenets of these services include testing for these three infections in antenatal clinics, prompt and effective interventions to treat women who are diagnosed with these infections to prevent transmission to their children, to counsel women and their partners, most importantly, to reduce transmission risk and ensure appropriate treatment. And that's not necessarily just at the outset in the pre-conceptual period, but also throughout the course of pregnancy and breast milk feeding as well. We really need appropriately attended safe deliveries for all babies and appropriate follow-up of infants exposed to HIV, syphilis and hepatitis B, and including Hep B, birth dose vaccine. We need to ensure there's optimal feeding and lifelong treatment and care for mothers living with HIV. To bring this all together, the WHO put together a regional framework for the Western Pacific region that was established in 2017. And on your right here is a table of the different targets that have been set forth and some of the milestones that they want to achieve. Now, this framework proposed an integrated and coordinated approach that emphasises a mother, newborn, child-centred care and a human rights-based approach for every child, mother, her partner and their families. And ultimately, what we do want to achieve at the end of the day is that we have antenatal care coverage above 95%, births attended by skilled health personnel above 95%, treatment coverage of HIV and syphilis above 95%, Hep B vaccine birth dose above 95%, and Hep B third dose coverage above 95%. So we're talking about 95, 95, 95, 95, 95, 95 here. So we don't get the 395s for HIV, we're getting the 695s here for triple elimination. And they're all achievable. And what I must point out at the very outset of this, these three infections are very easy to treat and prevent during pregnancy and early infancy. So this is achievable. Why don't we go forward? Now, whilst that's very achievable and it looks like we've got some very nice frameworks, policies and targets to achieve, how do you put this into practice? We've heard this before from Elliot as well. How do you put this into practice in the Western Pacific region? We have 37 member states and areas. Just look at it. We have got 22 Pacific Island countries and territories. We have quite an expansive geography, quite small populations. We've got island populations with this. So we've got populations within populations at countries. With diverse cultures, we've got very diverse cultures across the Asia-Pacific region with a whole range of different economies, low and middle income, higher income countries. So how do we do this of an overarching policy across these 37 disparate areas? It's really quite the challenge. Now, I want to focus on antenatal care first because this is the cornerstone of how we are to achieve triple elimination. And to Kathy's talk before around engaging women in care, pregnancy is such an ideal and opportunistic time to engage women in healthcare, not only for their own health, but in pregnancy, but also for their longer term health as well. So I can't stress enough for maternity care providers, paediatric care providers talk about this all the time. We hear about the gender-based inequities in health services. Pregnancy is a fabulous opportunity to get women into care, not only for the pregnancy, but for longer term as well. And it also allows optimal planning for care for newborns and linkages to relative care cascades. To Elliot's talk as well around advanced HIV disease and the high preponderance in the lower ages there. So getting these kids into care from the outset will provide their best chances of normal life. The WHO currently recommends at least 8 contacts during the antenatal period. What that means is that women who are pregnant should be seeing someone for their pregnancy care at least 8 times throughout the course of their pregnancy. However, this indicator is not routinely reported. Now, this data is from a meta-analysis done across the Pacific region here, and this looks at the rates or the coverage of antenatal care at least once, antenatal care at least 4 times, and proportion of births that were attended by a skilled health professional. You can see the light blue here is where we don't have any good data reported here. So that's one of the big concerns. We don't actually know a lot of the problem because we don't have the data to support it. We can see here that for at least one antenatal care visit, there's only one Pacific Island country or territory that has greater than 95%. And for those who at least had antenatal care at least four visits, there were no Pacific Island country or territories that had at least 4 antenatal visits for their pregnant women. And for those who had a skilled attendee at their birth, there were only 5 Pacific Island countries or territories that had more than 95% of births attended by a skilled health professional. So we are not really achieving anything if we aren't going to improve our antenatal care for women. What further to know is that the timing of the antenatal care is not reported in this. So whilst we might have, yes, 1 visit or we might have 4 visits, but the timing of these visits aren't reported. So they may not be in a timely fashion to provide any interventions as well. So there belies even further missed opportunities for timely antenatal interventions. So this is something that we really need to improve upon. This is from the Global Health Observatory data. So this are going through and taking out all that Southeast Asia and also the Western Pacific region countries in this. I won't take you all through it. The darker the blue, the higher the coverage. The lighter the blue, the lesser the coverage. But out of the 28 countries here that got data reported through the WHO, only 4 countries have antenatal care visits of 4 or more. For those who at least had a skilled birth attendant at delivery, 14 of 29. So still less than half of those countries that were reporting data actually had a skilled attendant. So again, antenatal care really probably substandard in a lot of places. And once again, if you notice in the columns there for the years, there are variable reporting timeframes as well. So the data is quite disparate as well. I've thought long and hard about how to approach this talk, and what I'm going to do, I'm actually going to talk about it in the 3 different infections. I know we started off with antenatal care, but now I'm going to break it down to the 3 different infections because it sort of reflects the silos that we've been going along for some time now, and now we know how to integrate these 3 silos. And you'll notice that throughout these 3, there's some common themes there throughout that we can really bring together. So in the Asia Pacific region, there's overall a low regional burden of HIV in women of reproductive age. That doesn't mean they're not an important group, as Kathy pointed out. They're just overall they're not as highly represented in the HIV epidemic in Asia Pacific, and that has implications because they're not considered a key population. They're not considered a target for a lot of the interventions and strategies that policymakers are putting forward as well. So they often miss out. But having said that, in Asia Pacific, our HIV mother-to-child transmission rate is more than twice the global estimate. So we've got a HIV transmission rate of around 19.2% for Asia and Pacific region, and that's from the most recent UNAIDS data. That's twice the global estimate for mother-to-child transmission, and it's 3 times the estimate for Eastern and Southern Africa. So we really have a problem here on our doorstep. Not necessarily in every country in Asia Pacific. Thailand's done a great job, but there are countries on our doorstep that are problems. As mentioned, Thailand's done a great job. There are 3 countries that have been validated for elimination of mother-to-child transmission for HIV. That's Thailand, Malaysia, and Sri Lanka. But there are many countries that have unacceptably high rates of mother-to-child transmission. There are several countries here that are in red that have transmission rates of around 30% or plus, which essentially reflects the natural history of mother-to-child transmission. So essentially, we have almost an unabated mother-to-child transmission epidemic occurring in many countries in Asia Pacific. Now, why are we in this situation? We'll first talk about antenatal testing. So we talked about actually antenatal care and how it's suboptimal, largely. Now it's about actually when you're in care, how can we get testing? Now, unfortunately, free universal testing is not universal. There are many barriers that women face and families face around the region. That includes out-of-pocket expenses. So even though you might have a model for HIV testing in pregnancy, an opt-out model, that doesn't necessarily mean that people have to pay for it. So a lot of countries that have opt-out models still need to pay for it. So therefore, people are choosing not to actually choose. People are opting out of HIV testing because they have to pay for it. There are also countries with their insurance, how their insurance works is they don't pay for screening, but they'll pay for diagnostic testing. So the semantics used here. So in policy that involves screening, insurance companies won't pay for screening tests, they'll only pay for diagnostic tests. So therein lies another issue as well. There's differential access between urban and rural areas, and also socioeconomic status as well. We also know that there are healthcare worker training, so we need better skilled trainers, healthcare workers to do risk perception, risk stratification, counselling and testing in pregnancy as well. There's also very low community awareness for HIV, particularly in some of the smaller island populations, particularly around risk perception. So they may not think HIV is a problem in heterosexual populations or other non-key populations, but it really is burgeoning in a lot of areas in that what's the non-traditional key population. Limited partner engagement. Now, this is a common theme throughout, is actually having the partner involved in a lot of the counselling and attending to antenatal care. Concern around the partner's reactions to a positive diagnosis, whether it be HIV, hepatitis B or syphilis, or how they might respond. We heard about the gender-based violence and partner-related violence before by Kathy. That's a very real thing. And so this ties in with all of that as well, is involving the partner in a lot of this. And of course, there's stigma, unfortunately, in a lot of these areas. Getting mothers on the treatment, we've got a test and they'll get on the treatment. So in Asia Pacific, around 64%, around 2/3 are estimated for women who are pregnant to be on antiretroviral therapy. When we break that down into the countries on the right there, you can see that there are a number of countries that are doing well. So Thailand, Malaysia, Cambodia there are several countries there that got really substandard coverage for antenatal management of HIV for maternal treatment. Now, why aren't these women being treated? This is a lovely graph there by Nat. Thank you, Nat, for this. So why aren't women on treatment? They might have a late engagement in antenatal care or a delayed HIV diagnosis, whether it be in late pregnancy, during birth or the breast milk feeding period. There might be attrition from care throughout antenatal care or antiretroviral stockouts, which we do see across the Pacific, particularly in low prevalence or low demand settings. We might only have a handful of women living with HIV in certain islands, and they can't get access to those therapies when women are newly diagnosed in pregnancy. This graph on the right here shows that these are the factors associated with new infants born with HIV. 80%, so the orange, teal and blue part, 80% are in mothers that are known to have HIV. The orange is that those that did not receive any retroviral therapy. The teal are those who did not continue any retroviral therapy, and blue are those that were on antiretroviral therapy but not suppressed. So 80% of infants who are born with HIV have mothers who know they have HIV. They're just inadequately treated. The other 20%, the red there are those that mothers are unaware of their diagnosis. Now, moving on to neonatal prophylaxis. So there are limited formulations available for neonates. This is due to pharmacokinetic and pharmacodynamic complexities and also slower development of age and weight appropriate formulations. Currently, this table here shows the current recommendations for neonatal prophylaxis. You can see the high reliance on zidovudine and nevirapine, particularly in the WHO guidelines, which really inform a lot of the low and middle income countries. But drug resistance is further limiting these options moving forward. This is data from PNG. A couple of years ago now, shows that this is the drug resistance data for adults living with HIV in Papua New Guinea. You can see in the top, that's ART naive adults. You can see NNRTI resistance of around 12%, NRTI resistance of just under 3%. But when you've got ART exposed adults, you can see that NNRTI resistance is over 40%. So really, nevirapine as a antiretroviral neonatal prophylaxis in these sort of settings may not be the most appropriate agent moving forward. So where can we go from this? So in the pipeline moving forward, we've got raltegravir. There are raltegravir granules for suspension. Now, these are already in some international guidelines are being used. There's good data there for dosing, pharmacokinetics and safety. There's also some recent data out around lamivudine dispersible tablets or lopinavir and lopinavir granules as a combination therapy. There's been some formulations being seen safe and drug exposures are similar to those in infants. So that's an option moving forward. And obviously dolutegravir. There are some modelling studies that show some dosing data around this. And there's also some trials currently underway looking at tolerability, safety and pharmacokinetics, both for the oral suspension and the dispersible tablet. Obviously, people really are hanging out for what these studies show for the DTG. Now, infant testing, there's a wide variation in access to infant PCR testing. We do need to do PCR testing for infants because if we rely on serology, we'll often pick up the maternal antibodies. So we, as you see in the yellow here, quite a range of access to infant PCR testing, which we try to do at least by 2 months of age. There are several countries with no in-country capacity for molecular diagnostics and have to send their dried blood spots internationally. There are some countries with highly centralised laboratory capacity, and that leads to very limited testing coverage. And there are some point-of-care testing platforms that have been upscaled in some settings as well, such as Papua New Guinea and Timor-Leste, that's really emerging at the moment. All right, moving along to hepatitis B. So this slide, really important, just shows that the dotted line is the proportion of people who have chronic infection or get chronic infection by the age of acquisition. The solid line is when they develop symptomatic disease. Birth is the highest risk period for developing or establishing chronic infections. So we need to actually attack it there and now. Now, going again through some of the screening for hepatitis B, you can see here a lot of the data, similar meta-analysis before with HIV, the data is really disparate, and really we don't really know much about the Pacific Island countries and how much screening is done for hepatitis B. You can see those grey areas here, essentially no data. In the Asian countries here, I don't expect you to read through all of this, but this is some of the meta-analysis looking at sort of Hep B screening in women, more around the prevalence of Hep B surface antigen. And you can see that there are countries with not a lot of data, there are countries that have very subnational data and different timeframes as well. So again, we don't really have a good handle on a lot of the burden of being mothers, pregnant mothers in antenatal clinics. Now, Hep B birth dose vaccine is an incredibly effective intervention. Just alone, if you give Hep B vaccine at birth, just alone you'll prevent somewhere between 70 and 95% of Hep B transmission to mothers. If you have the 3-dose schedule, so you give the birth dose, then you give 3 doses thereafter, or include it in 3, there's some 3-dose schedules and some 4-dose schedules, you'll actually have more than 95% effective in pregnant-mother-child transmission. These are vaccines that are well established. They're safe. We know we use them. They're in routine immunisation programs. We just need to get them out there to the kids, to the infants, that is. And you can see that this is a few years old now, but on the right there just shows which countries have implemented, the blue countries have implemented birth dose vaccines. Now, some countries do have access to Hep B immunoglobulin, and that can increase protection, particularly for mothers that have high viral loads or Hep B E antigen positive. They're the higher risk transmission scenarios. But again, not all countries have access to Hep B viral load testing or Hep B E antigen testing. And again, Hep B immunoglobulin, the storage, the cost, and the other logistic requirements might preclude its access. Now, looking at vaccine coverage here, on the left you can see a graph. This is more relative to the Southeast Asia countries. You can see that in the light blue and the dark blue, they have Hep B coverage of both the birth vaccine and the 3-dose schedule greater than 90%. So these countries are doing quite well. And you can see here that the dark blue have also got a Hep B surface antigen prevalence in those under 5 of less than 1%. So those countries, Nepal, Bhutan, Bangladesh, Thailand, doing really well from a Hep B perspective. There are many countries there that still need to do more. The table on the right is for the Pacific and Island countries. You can see here that we have antenatal Hep B screening, a lot of uncertainty around the data here. We don't know much about this. Hep B birth dose, again, very variable. Obviously, a number of countries there are able to give the birth dose vaccine, but still several countries that aren't achieving that 95%. And then looking at the 3-dose coverage, again, you can see there are a handful of countries that are in around 95%, but several countries either with no information or below that 95% and quite low. So we really need to do more around this. Now, what are the challenges to giving the birth dose vaccine? Well, it's actually getting access to appropriately stored vaccines. So there might be some cold chain requirements or actually physically where they're located. This chap here on the top right, he's actually carrying his newborn from the delivery suite across a very, very busy road and intersection to the immunisation centre. So that's just one of the simple structural barriers that people are facing in regards to getting the Hep B birth vaccine. Vaccine stockouts, obviously procurement is a huge issue. There's 37 member states and countries across Asia Pacific. Getting procurement changed throughout the Pacific are really challenging, particularly in the times of COVID, dare I say it, with the supply chains that really were decimated, particularly for the Pacific, and only getting back into normal levels there. birth unattended by a skilled provider or a dedicated staff member to give actually the birth dose vaccine. So at the bottom here is actually a mother who's just given delivery, given birth. So I should say we've got one healthcare worker that's got 3 fingers in the air talking about the 3 doses for the Hep B vaccine, and another provider there giving the birth dose vaccine to that child. So this is the ideal scenario in regards to actually counselling and having dedicated staff to giving the Hep B vaccines, both at birth and informing about the 3-dose schedule. Poor health literacy obviously goes without saying across all these 3 infections, and many aspects of antenatal care is really important, and we need to improve. And the lack of community outreach. So obviously home births or births that might be delivered in regional settings, mountainous regions, highlands, remote islands, we really need to look at ways how we are going to be doing outreach to those really far-flung places that women are delivering as well. How can we achieve this? How can we improve this? So we can actually look at different ways to improve vaccine access. There is some data out there, the studies done in Solomon Islands around actually relaxing the cold chain requirements, and that you can actually give the Hep B vaccine up to 30 days outside of the routine cold chain environment. We can think about novel devices. So say, for instance, Timor-Leste and other areas are using pre-filled auto-disabled devices as well. And we can also look at novel deliveries via drones as well. We also need to upskill and train staff and dedicate staff to deliver the vaccine across those various models of peripartum care, whether they be in a tertiary setting or a hospital setting versus a community outreach setting versus a home setting, wherever the setting may be. Obviously, there's very different cultures across around how we deliver care for women who are pregnant and their babies. Just a quick note on maternal treatment. So we spoke a lot about the vaccine, so we can potentially treat the mother with things such as tenofovir. That does reduce the risk of mother-to-child transmission for women, mainly in the setting of high hepatitis B viral loads, and typically the cutoff's been over 200,000 there. It might actually be 2 million, sorry, Gal. I might be missing a zero there. By giving the tenofovir, it's been estimated in high-risk situations, it's been estimated to prevent an additional 3 million neonatal infections between 2020 and 2030. But in order to be able to identify those women who will benefit from tenofovir, we need to actually test for viral loads. And obviously that capacity doesn't exist in a lot of regions, a lot of countries in this region. We could utilise existing GeneXpert platforms and other emerging testing platforms as well. Another consideration is actually doing Hep B e-antigen testing instead of Hep B viral loads. So e-antigen positivity is not a perfect science, but sort of correlates with higher HBV viral loads and a higher transmission risk as well. So if you've got a Hep B e-antigen positive mother, your risk of transmission to the fetus is much higher, as you can see there, compared to those who do not have e-antigen. So you can consider Hep B e-antigen testing in these situations. Now, you might come across similar pitfalls to access similar to viral load testing, but also you might be able to do some RDTs in Hep B antigen that might overcome these access issues, and you can integrate these hepatitis E antigen RDTs with the other screening for for syphilis and HIV as well. And obviously, you can consider other roles, combination Hep B E antigen and ALT algorithms to identify women who are high risk of Hep B transmission and can be eligible for tenofovir. Furthermore, Hep B infant testing. So we need to follow up these infants who've been exposed to hepatitis B during pregnancy, but we really have incomplete capturing of this cohort. You can see in this table here, this is for the Western Pacific region. Only 7 of the 36 countries that are in this reporting data in this actually have follow-up testing reported for Hep B in infants exposed to Hep B during pregnancy. There are 9 that don't implement it out of that 36, and there are 20 without data. So we really don't have good data on capturing our infants exposed to hepatitis B. Moving on lastly to syphilis. So this is WHO data looking at syphilis testing on the left here among women in antenatal care. You can see the dark blue over 95%, so doing well there in a lot of countries. And as you get into the orange spectrum, as you get towards further south in Southeast Asia and towards the Pacific, you can see that the coverage is really quite low, less than 50 or even less than 25%. And again, a lot of those countries there, getting in towards the Pacific region here, are the highest syphilis prevalent areas as well. So moving more closely down to the Pacific countries here, back to this meta-analysis, you can see here, again, we've got some high-risk countries in the darker shades of green. The two darker shades of green are the sort of above 5%, which is the typical threshold for high risk. A lot of countries in the grey here with not really good data on where we're going with syphilis in pregnancy. Now, why? So antenatal screening for syphilis. So there's some complexities here. This is, I guess, an overarching algorithm for syphilis testing and treatment in pregnancy. As you can see, there's so many different ways you can really pick your path through this. That comes down to what the prevalence of syphilis is, what your current system involves with coverage, treatment and testing. Do you have laboratory capacity? Are you reliant on rapid testing? So there are many different avenues you can take, and this can be quite complex. And you do need serial testing throughout pregnancy. So obviously women remain at risk for syphilis throughout pregnancy if there's repeated exposures. So we do need serial testing throughout pregnancy. And of course, back again to stigma and discrimination. We obviously talk about in the HIV setting quite a lot, but syphilis, hepatitis B suffer similar things. Some enablers. So we know that the HIV syphilis dual point of care testing has really improved antenatal testing for women in pregnancy, and obviously there's some emerging point of care platforms for both treponemal and non-treponemal tests. Now, WHO have tried to simplify this. This is the more simplified version algorithm that a lot of countries are adopting. So this is where we start with a screening test, so a rapid screening test. If that's positive, then you give your first dose and maybe your only dose of intramuscular penicillin, and then you might go forward to a more lab-based test with the RPR. And then if that's positive, then you can actually try and determine whether you need a second dose of intramuscular penicillin. So again, we've tried to simplify as much as possible the testing algorithm to make it easier. Now moving on to maternal treatment. So IM intramuscular benzathine penicillin is a standard of care. Very, very effective if you give it appropriately. But however, we do need alternatives. We have a penicillin shortage globally at the moment, and it's only going to get worse. The estimated doses between 2019 and 2030 are going to more than double. So we need to get better access to dose penicillin, but also look at some other things as well. There are women out there who are allergic and don't have access to desensitization protocols. Acceptability of getting intramuscular injections there once or twice, acceptability of that is not necessarily great. And other options currently for treating syphilis, particularly in women, you're looking at pregnancy, at least we're talking about here, is erythromycin and azithromycin, oral agent. Yes, they might treat the woman, but that doesn't cross the placenta and does not treat the fetus. And so you still need to follow up treatment for the fetus. And there's increasing risk rates of macrolide resistance. There are a few oral agents under evaluation. Also, there's ceftriaxone out there, but it's a 10 to 14 day course, and there's limited data about the acceptability and feasibility for this in this sort of setting. On infant testing, so clinical assessment by skilled health personnel is critical for syphilis. 60 to 90% are going to be asymptomatic, but will become symptomatic, most of them by 3 months of age. And we do have a reliance on diagnostic testing, given the high proportion of asymptomatic infections. However, there's limited access to PCR testing for treponema pallidum, and we do rely on serology, which challenges with this interpretation. And there are many countries out there that rely on probable case definitions for congenital syphilis, which means that they rely on the maternal tests, and that's what the infant looks like at birth, without any confirmatory testing in the infant. So we really need to improve infant testing there. Now, there are point of care, obviously testing for adults, but they haven't been evaluated in neonates. We can't rely on IgG-based treponemal assays because they will reflect maternal IgG, and the non-treponemal assays for point of care are qualitative, so they don't give you an estimate of the quantitation of the titer, which you do need to rely upon when comparing with the mother's titer in trying to confirm syphilis in the baby. There are some dual treponemal and non-treponemal assays available, but they're not currently made by the WHO. All right, I know I'm running out of time here. I'm going to have to really shoot through. Treatment for syphilis in kids, penicillin again is the key, very effective, but we need to think about other options. Single dose IM benzathine penicillin, ceftriaxone, oral antibiotics, or specific regimens for those that are either high risk or symptomatic, or low risk and asymptomatic infections as well. Now, triple elimination validation. Again, we've got the framework to do this, but we do need cross-sectional surveys of this. We don't, as you can see with the lack of data for a lot of these, our passive surveillance systems aren't robust enough. We do need to do active surveillance. And our summary national estimates may not adequately reflect prevalence estimates in island populations, so we need subnational data. So how do we overcome these challenges in the last 30 seconds? We need multi-sectorial commitment to provision of free universal testing for pregnant women. We need novel antenatal testing strategies, improving convenience through self-screening or community-led programs, integrated multiplex point-of-care diagnostic algorithms, serial testing throughout the at-risk period in pregnancy and breast milk feeding that is backed by enhanced laboratory capacity for confirmatory testing. We need to increase community awareness and healthcare worker training to improve health literacy for the community and really engaged partners. We need to upskill the workforce across the many models of maternity and newborn care services across this very brilliant, large, diverse region. We need to advance the pipeline for therapeutic and prophylactic agents in pregnancy and newborn to meet the evolving epidemiology and health system requirements. So we need a more dynamic response to implement the use of these emerging agents. So we need endorsements from ministries and WHO. We need to take on what these emerging therapies are going to do. We need to minimise the economic barriers to implementing these as well. And we need to embed biomedical and operational research into antenatal care strategies and newborn care strategies for these. And we need to strengthen these vulnerable supply chains for diagnostic and therapeutics in low prevalent and small populations. There's so many stockouts, not only for drugs, but also for biomedical devices and testing kits. We really need to develop these regional networks to help our buying power, our purchasing power, to get that over the line. Last slide, I promise. Surveillance systems. We need to have robust, passive and active reporting mechanisms across maternity and child health services at a subnational level that can go across the different models of peripartum care. And that'll help us report the triple elimination indicators and support programmatic decision-making and resource allocation and help our preparedness for validation for elimination as well. And lastly, but not least, it goes to the last two talks as well. We need to address the structural health inequalities. That's gender inequities. We need to improve in universal care coverage, decriminalise and improve the quality of care for women who are pregnant and their babies. Thank you.